Hello. Good evening, everyone. All right. In this session, we will be discussing the predictor questions or predictor topics for upcoming INICET exam. And I will be discussing the CVS and GIT portion of INICET. From the CVS, usually 2-3 questions, and from GIT, 2 questions come. And the topics are repeatedly asked, but in depth. So, for the cardiovascular system, important topics to be considered are the topics of coronary artery disease. They ask questions on ECG, heart failure, questions on clinical aspects of murmurs and auscultatory areas. So this is a very, very important section for cardiovascular point of view. And in the pericardial disease, they do ask the topic of tamponade, emergency medicine based questions. While in the GIT section, so these are the high-yielding topics of cardiovascular system. Now, in the GIT, usual topic to be asked are IBD. Celiac disease is a favorite topic of INICET, and in the liver section, it is the serology based question which are very frequent, like hepatitis B serology and complications of liver failure like ascites and Wilson disease. Wilson disease, but they ask in depth. They ask in the depth. Now, coming to the questions one by one. So this session is just to give you an idea about the topics and how the options are being ruled out. So starting with the question number 1. So hopefully you must have attempted these questions on your NEET app. So starting with the question number 1. So question number 1 is diabetic male presents with chest pain, diaphoresis. ECG is shown in this figure. Troponin level is elevated. Now this is a image based question, ECG based question about the which wall of the heart is affected and which artery supply that particular wall. So let me wait for your answers. So okay, how can I make this topic strong? This is with multiple revisions and try to identify your weakness, key where you are lacking. So work on those weakness. So all right. So I am getting the answer as a left circumflex. So if you see this ECG, so in the ECG, start with the lead 1, and in the lead 1 you can see that ST segment is elevated. This is elevated from the baseline, and when the changes are seen in lead 1, so go to lead AVL. So ST segment is elevated there also. So there is a ST segment elevation in the lateral wall. So 1 and AVL, it represent a lateral wall, and the blood supply of the lateral wall is left circumflex artery. While for the right coronary artery, it will be inferior wall, and inferior wall leads are 2-3 AVF. 2-3 AVF. While LED, it supply the anterior wall and the septum. So it will be V1 to V4 for LED. That will be the proximal descending LED. Distal LED, it supplies usually the apical part, apex, and apex is usually V4. It will be V4. So the answer here will be left circumflex artery. Most of you have given me the correct answer. So single most common organism causing prosthetic valve endocarditis, number of year is not mentioned, then it is cons. So now moving on to the next one. So question number 2. Okay, question number 2 is a clinical question on this cardiac disease. 23-year-old athlete collapses during a basketball game there is a crescendo decrescendo systolic murmur at the left sternal border, which increases with standing and the Valsalva. So most likely cause of this presentation is, so if we see one by one, so we should rule out the options. So how we rule out the option? Aortic stenosis due to bicuspid aortic valve. So in aortic stenosis, it is ejection systolic murmur, but it will be best heard at right second intercostal space. Right second intercostal space. So this is not the correct answer, and this will decrease with the standing and the Valsalva maneuver. Pulmonary valve stenosis is ejection systolic murmur at left second intercostal space. This how we can, mitral valve prolapse is a late systolic murmur. Late systolic at apex. While HOCM, ejection systolic murmur at left third intercostal space. So intercostal space is also important, and the exception is also important that these two murmur, HOCM and MVP murmur, these murmur increase on decreasing the blood flow, and blood flow is reduced by Valsalva, and blood flow is reduced by standing position. This is the characteristic feature. This is the characteristic feature. Yes. So by this, you can easily identify and rule out the other options for this question. So HOCM is an important topic for your INICET exams. So hopefully all of you have given the correct answer. Yes, this is the correct answer. Now moving on to the question number 3. Okay, so let me wait for the answer here. Which of the following findings most specifically indicate that there is an isolated right heart failure due to core pulmonale? So what will your answer here? Because heart failure is an important topic. Clinical feature and drugs are asked from the heart failure. All right. So elevated BNP, bilateral pedal edema, parasternal heave, or orthopnea, which will be the feature which will suggest that it is an isolated right ventricle failure. This is clear cut written, because reason is most common cause of right heart failure is left heart failure. But here isolated is mentioned. The problem start with the right side. So elevated BNP is increased in both right and left. It will not differentiate. Bilateral pedal edema will be positive in both right and left heart failure. Orthopnea is a feature of left heart failure. While parasternal heave is that right ventricle hypertrophy is occurring, right ventricle heave is producing. So this parasternal heave is specific for right ventricle pathology or right ventricle failure due to core pulmonale. So answer here will be parasternal heave, not bilateral pitting edema, because yes, it is seen in both the cases, right as well as left heart failure. And also in the heart failure, the treatment is very, very important for you to know that first line agent we will give, and what are those first line agent that should be on your tips. All right. So question is question number 1. 2 and AVF also has ST elevation. Let me see if there is a ST elevation in 2, 3 AVF also. No, absolutely no. In lead 2, it is ST depression. 3 ST depression is there, and AVF ST depression is there. No, it is not elevation. So identify it clearly. These are reciprocal changes in 2, 3 AVF due to 1 and AVL ST elevation. So definitely no. All right. So now coming to question number 4. Now this is a potential question way forward, because AIMS people, they ask a question from common topics but in detail. So what is your answer to question number 4? So the question number 4 is 70-year-old man with AF, recent GI bleed, CHARTS score of 4 is being considered for anticoagulation, which is the most appropriate next line step. So start the EPIC 7. Remember, CHARTS score of more than equal to 2 is an indication for giving the anticoagulant therapy. They ask the scoring. But the most important thing is कि patient has recent GI bleed. So if there is a recent GI bleed and you give anticoagulants, the bleeding risk will be more. So we have to balance the bleeding risk and the anticoagulation benefit. So for that, we calculate a scoring system known as Haas-Blad score. And if this score come out to be more than equal to 3, that means there is increased bleeding risk with anticoagulation. So therefore, we evaluate this risk in the patient and we will consider a left atrial appendage occlusion so that thrombus usually develop in the appendage of left atria. So we will occlude that appendage. So thrombus will not be made there and there will be as such no need for the anticoagulation therapy. So the full form is hypertension, abnormal renal and liver functions. S stand for stroke history. HAS. H is hypertension, A is abnormal renal or liver function, stroke A history will make it. So 1 point each will be there, and B is bleeding, which is present in our patient. GI bleeding is there, and L. The L will be labile. INR means INR is fluctuating. This is L, labile. Labile you can say very high INR also. E stand for elderly. Elderly means age more than 65 years. And D stand for drugs like NSAIDs, which predisposed the patient to low platelet count and bleeding risk. So therefore this will be assessed. Haas-Blad score will be assessed, and if it is more than equal to 3, we will defer the anticoagulation and we send the patient for the procedure. So answer will be C option here. No role of aspirin and clopidogrel. These are antiplatelet agents. They have no role in a AF induced thrombus. So the answer is C option, the best answer. Now question number 5. All right, so question is, yes, each will be given a score of 1. 54-year-old woman with diabetes presents with epigastric discomfort. Why can't B be the answer here? So the best answer you have to choose. Defer anticoagulant due to bleeding risk, but we should go for the procedure also because the thrombus is there. So out of B and C, choose C as the best answer. Okay, now come to question number 5. So question number 5 is diabetes patient, ECG, T inversions, troponin is elevated. Coronary angiography shows 70% stenosis without complete occlusion. What is your diagnosis here? So the diagnosis here is I am getting the answer as non-escalation MI. So if you look at the ECG and the troponin levels. So ECG in unstable angina, ST depression, and troponin will be normal. Non-escalation MI, ST depression, but troponin will be high. ST elevation MI, this will be high. While silent myocardial infarction, so whenever silent myocardial infarction occur, assume it to be a ST elevation MI only because they are more common. So the answer here will be non-ST elevation MI will be present. And most important thing is the treatment aspect. So the treatment aspect of non-ST elevation MI, treatment. Most important thing is conservative, and they have asked so many times this question like dual antiplatelet treatment, antithrombotics will be given, nitrates, beta blocker, and contraindicated is thrombolytic agents. Contraindicated will be thrombolytic agents. So the mainstay of treatment is conservative. So answer to this question will be option number B. Now, coming to question number 6. As I told you, for the GIT, important topics are the IBD, celiac disease, malabsorption syndrome. In liver, it is hepatitis B, especially its serology, and complications of hepatitis, as well as the Wilson's disease. So coming to question number 6. So question is, patient has weight loss, chronic diarrhea, and colonoscopy reveals transmural inflammation, granulomas, and skip lesion. So which of the following complication is most specific to this condition? So let's identify which condition is this diagnosis. So transmural inflammation, presence of granulomas and skip lesion. So 100% diagnosis will be it is a case of Crohn's disease. It is Crohn's disease. So this IBD should be on your tips, Now let's see, toxic megacolon. Toxic megacolon is more in ulcerative colitis, much more than Crohn's disease. About the primary sclerosing cholangitis, so this is typically ulcerative colitis, much more than Crohn's disease, CD. Now, perianal fistula. Fistula is most specific for Crohn's disease. This is seen in CD only, not in ulcerative colitis. While colorectal carcinoma is seen in both, and the risk is equal. Ulcerative colitis, Crohn's disease, risk for colorectal cancer is exactly same. Fine. And can anyone tell me which extraintestinal manifestation is equally seen in UC and CD? Extraintestinal manifestation, which is seen equal in both the condition. Yes, primary sclerosing cholangitis, and indeed pyoderma gangrenosum is more in UC. Pyoderma gangrenosum. It is more in cases of ulcerative colitis. So the condition, no, uveitis. Uveitis is more common in Crohn's disease. So answer is not uveitis, it is sacroiliitis. This extraintestinal manifestation is equal in both UC as well as in CD. Yes. And other aspects of the inflammatory bowel disease which you should be focusing upon is the management aspect. So treatment is of vital importance in cases of UC and Crohn's disease. Stones are seen in Crohn's disease only. So and these are oxalate stones. It is seen in Crohn's disease only, not in ulcerative colitis. Oxalate stones, to be precise. All right, now come to, yes, so let me check who will give me the correct answer for question number 7. 29-year-old male presents with chronic pruritic vesicular rash on the extensor surface of elbows and knees. He has no GI complaint. Skin biopsy from the lesion shows a granular IgA deposition at the dermal papilla. What is the most appropriate next step in the management of this patient? So I am getting the answer as option number B. Okay, in previous question, pyoderma only in UC. No, pyoderma will be more in UC than CD. All right. So, when patient has been diagnosed as dermatitis herpetiformis, this is the skin lesion dermatitis herpetiformis. So this is highly associated with celiac flu. May not be key patient will have GIT symptoms. So this could be the sole manifestation of celiac disease, dermatitis herpetiformis, and presence of these granular IgA deposits that goes in favor of dermatitis herpetiformis. So once it is diagnosed, then we will start a patient on a gluten-free diet and we can do the anti-TTG antibody. Here duodenal biopsy will not be needed. It will not be needed. Why not option number D? Start Dapsone and monitor the rash resolution. So dermatitis herpetiformis, what happens ki, if you start the patient on a gluten-free diet, it will resolve. It will resolve these clinical manifestations. They do respond to gluten-free diet. Gluten-free diet. Yes. Not specific, and biopsy is not totally 100% specific because we need to do a repeat biopsy after a gluten-free diet. After a gluten-free diet, yes. So question answer will be option number B. Slightly tricky question. All right, now I will wait for question number 8 and I will give you the diagnosis here. The diagnosis here is Clostridium difficile, CDI infection. CDI infection. Do we routinely do serum IgA in celiac disease? Yes, we do check because these patients are deficient in IgA. Deficient in IgA. All right. So 76-year-old female, confusion, hypotension, diarrhea for 2 days, and she received ceftriaxone for pneumonia 10 days back. Vitals, low blood pressure is there, WBC count is high, creatinine is 2.3, which is also high. CT abdomen shows diffuse colonic thickness. Stool toxins assay is positive. Most appropriate next step in the management of this patient is. So, the answer here will be this is a Clostridium difficile infection. So if someone asks you what is the DOC for this, the drug of choice for Clostridium difficile is oral fedexamycin. This is the DOC. But here the most important thing is the fulminant CID is given. So this is not a plain CDI. This is not uncomplicated CDI. This is fulminant CDI. So fulminant CDI features are WBC count are high. More than 15,000 is fulminant. Creatinine more than 1.5 is fulminant. Patient is in shock. So these goes in favor of fulminant, and in fulminant we gave vancomycin plus IV metronidazole. Why? Fecal microbiota transplantation is given for refractory cases. Not all the cases, only refractory cases we will be giving here. Where oral vancomycin is now not preferred for the plain uncomplicated Clostridium difficile infection. So answer will be C option here. Yes, patient should be given combination. Yes. Now, coming to this important topic of ascites, the flow chart of the ascites, ki how should we make a diagnosis? So the most important thing in making a diagnosis of the ascites is this SAAG gradient. This is of importance. If this ratio is more than 1.1, that means the ascites is due to high sinusoidal pressure, which can be due to cirrhosis or post-sinusoidal causes. While if SAAG is less than 1.1, then the cause can be a nephrotic syndrome, inflammatory conditions like TB or cancer or pancreatitis. And to rule out cirrhosis or post-sinusoidal causes, we will check ascites total protein levels. So ascites total protein levels, if are less than 2.5, it is a case of a cirrhosis. And if more than 2.5, it is post-sinusoidal causes. Post-sinusoidal, like Budd-Chiari syndrome, CHF, these will be the causes. So I have given the flow chart. Apply the variables in this flow chart and your answer will be 100% right. So if we look at the SAAG, it is more than 1.1. Total protein is less than 2.5. So 100% answer is cirrhosis. While in malignant ascites and tubercular peritonitis, SAAG should be less than 1. Yes. And Budd-Chiari syndrome, this will be proteins, total protein in the ascites fluid, ascites proteins should be more than 2.5. Here it is 0.8, just 0.8 is given here. So answer is C option. 100% you will get the correct answer. Now, next one. Okay, this topic. This is a guaranteed question. One question always asked from the hepatitis B serology, maybe hepatitis B with hepatitis D also. So question is, which of the following best differentiate acute hepatitis B from a chronic carrier condition? Very, very simple question. So acute hepatitis, the most reliable marker you should check. So for acute hepatitis, most reliable serological marker. Yes, the most reliable serological marker is, yes, correct. It is IgM anti-HBC. So this should be there. While what is the meaning of a chronic carrier condition? Chronic carrier condition is nothing but a case of a chronic infection, and chronic infection means we should have IgG antibody, IgG anti-HBC with HBs antigen. That is a serology of chronic. So the answer, and in cases of acute and chronic, the marker which is common is surface antigen. HBs antigen is positive in both the cases. So the answer here will be IgM. While anti-HBC S positive means this is a post-vaccination marker. Post-vaccination marker. If only this is positive. Anti-HBC is positive post-vaccination. So the answer here will be C option here. All right, now coming to the question number 11. So question is, cirrhosis patient develops altered sensorium, and altered sensorium means ki most likely a case of hepatic encephalopathy. So I'll give you the diagnosis and you give me the correct management, first step in the management. So this is hepatic encephalopathy. In acute IgG will not be present. So it also, yes, so question answer was IgM antibody, na? IgM antibody. So hepatic encephalopathy is present and patient has a low potassium value of 2.8, low potassium of 2.8. So the answer here is we have to treat, the first line is treat precipitating causes, and one of the precipitating causes is hypokalemia. Why hypokalemia? Because it causes decrease peristalsis. Decrease peristalsis means increase bacteria, and increase bacteria means increase ammonia. Because bacteria proliferate, they produce the ammonia. So there will be no use of giving the lactulose unless you treat the hypokalemia. So first treat always the precipitating factors, and in this case we will go for hypokalemia. Though all the four options can be used. Lactulose is used, rifaximin is used, mannitol is used. Mannitol is used if there is a cerebral edema. Cerebral edema. So all the four options. So you have to pick the best answer. The best answer is first step, always and always treat precipitating causes. Vanco can be given in raised creatinine. Vancomycin means ki if you are giving vancomycin, then KFT has to be checked, means ki it should be avoided in a deranged kidney function test. But if you are giving orally and enema wise, then there will be no issue as such. Now, question number 12. Ascites fluid shows a neutrophil of 340 and negative culture. What is the next step in the management of this patient? So patient has cirrhosis and patient has ascites. Neutrophil count is more than 340. So the diagnosis here is spontaneous bacterial peritonitis. So this is clear-cut answer here. Spontaneous bacterial peritonitis is the answer. So in the spontaneous bacterial peritonitis, the hallmark will be ascites fluid. Ascites fluid. neutrophils. The cutoff for neutrophils is more than 250. This is the most important point. And proteins. Proteins here will be less than 1 gram per deciliter. So proteins are low, and SAAG will be more than 1.1. Now, though the culture will be positive, or here negative culture is given, maybe the bacterial growth was not so high to give the culture positivity. But still, we will start the patient on empirical cefotaxime, that is the drug of choice here. Observe and repeat the culture? No, never wait in SBP. It can flare up like anything. So you have to give patient antibiotic therapy. Do not rely on the culture. Culture may not be sensitive to give a positive value of E. coli. Repeat paracentesis in 24 hours. There is no need to wait and watch. We have to give empirical cefotaxime. Now, all right, so coming to the chronic hepatitis based questions. Question is, which of the following lab profile is more characteristic of alcoholic hepatitis? So in cases of alcoholic hepatitis, if the option given to you is carbohydrate deficient, transparent, increased level of CDT, increased level of CDT. So if this is increased, pick this as the most specific. But if it is not given, then the other will be AST ALT ratio. This should be more than equal to 2. D-Ritis ratio, that will be more than 2. And very, very characteristic point, absolute values of AST and ALT are up to 400. They does not go beyond 400 in alcoholic hepatitis. Why? Because of the fatty infiltration, gamma GT is elevated. So the best answer here will be A option. AST ratio is 2. Both will be less than 400, and there will be elevated gamma GT. Reason is not obstruction. Reason is fatty liver. Fat squeezes the endoplasmic reticulum, and gamma GT of endoplasmic reticulum will be leaked into the plasma. So it will be elevated here. So answer is A option. And in the alcoholic hepatitis, what else you need to know is the MADRS discriminant function. That is important. Any scoring system you should be knowing for liver. So it's a MADRS discriminant function, which is 4.6 multiplied by prothrombin time of the patient minus prothrombin time control plus serum bilirubin. That is the MADRS discriminant function. If it is more than 32, then it will be indication for giving steroids. Okay, now coming to question number 14. Question number 14 is patient has behavior abnormalities, poor academic performance, new onset of hand tremors, examination shows dysarthria, mild rigidity. There is a family history of liver failure, AST, ALT are high, and a most important thing is serum ceruloplasmin is low, and urinary copper levels are normal. They are given. So I don't know why they are normal. They should be increased. Slit lamp examination is inconclusive. What is the next best step to confirm the diagnosis? So for confirming the diagnosis, you need gold standard investigation. So what is the gold standard? Answer is biopsy. So liver biopsy with quantitative hepatic copper estimation will be done, and the level of hepatic copper should be more than 200 microgram per gram of dry liver weight. While brain MRI for basal ganglia hyperintensities is not sensitive, we never give a trial of penicillamine unless diagnosis is proved. approved. And urinary copper level, they are not so sensitive to give you a correct picture. So answer is A option, and the value should be more than 200. And the scoring system here is Nazar score for Wilson disease cirrhosis. If Nazar score is less than 7, medical treatment will be given. And if it is more than 9, it will be liver transplantation. So you should be knowing the appropriate scoring for a particular chronic liver disease. Now, coming to the highly expected question, because this terminology has been changed recently, and that terminology is MASLD. So most likely it will be asked. So MASLD means it is a metabolic dysfunction associated steatohepatitis liver disease, steatotic liver disease. So which of the following support the diagnosis in this case? So A option, liver biopsy showing macrovascular steatosis and balloon degeneration. Remember, macrovascular steatosis can also be positive in alcoholic liver disease also. So it is not specific. Exclusion of all the causes of the disease. This is a new change. Means ki previously other causes of the liver disease has to be excluded, but now it is not needed. Even if patient is taking alcohol, but metabolic syndrome is present, so you call that as MAT-ALD, metabolic liver disease with alcoholic liver disease. So no need to rule out the other causes of fatty liver. So C option is most accurate, presence of metabolic risk factors and imaging evidence of hepatic steatosis. So fatty liver in the ultrasound and metabolic risk factors like same one that are used for metabolic syndrome. Metabolic risk factor means metabolic syndrome. While control attenuated parameter, this is nothing but a fibroscan that is suggestive of the fat. More than 260 is a fatty liver. But fatty liver can be seen in alcoholic liver disease also. So the answer here will be C option. So in this session, these were the questions which I have covered, and 1-2 question have been left, so I will give the answer. So there was a question which are asked from you is in spontaneous bacterial peritonitis. It is a bacterial infection. So why SAAG is more than 1.1? The reason is because it is cirrhosis induced, and in cirrhosis SAG will be more than 1.1. And if any other question are there, you can type your question and we'll discuss that question. All right, so if there is no further doubt, so we will wind up with this session, and wishing you all the very best for this upcoming exam. Okay, what is a good score for this level of for this 15 questions, the good score will be 2 wrong option, 13 questions should be correct. 1-3 questions should be correct. Drug of choice for NASH is semaglutide. No, semaglutide is still not approved without diabetes.